All right, welcome everybody. Thank you for joining. Appreciate taking the time today. We're going to be talking about prior authorizations for medications. And so Eric and then eventually Haley from WVU Medicine are going to be joining us here to walk us through the didactic portion. Again, if you've got questions, you can put them in the chat. You can wait till the end, raise your hand, unmute, whatever your preference is. We'll have a discussion afterwards. I'll go ahead and start sharing my screen. Eric, if you want to go ahead and introduce yourself, then you can take it from there.
Sure, absolutely. Nice to meet all of you all. My name's Eric Dunathan. I am the MS coordinator and nursing supervisor here at WVU Medicine. I've been in neurology for 10 years, working with our multiple sclerosis patients, which has vastly grown in the last decade. Um, and so I've seen kind of the growth as far as, the medications across our spectrum in the last decade, patient access, how to optimize that, especially for our rural population. And this is, and I say this because there's so much depth that I could go into for prior auths, and I would bore you all to death. And honestly, it is very boring. So we tried to like make it as not boring as possible, but there's not a lot of information. So please, at the end of it, if you have specific questions, I can answer to the best of what you want me to answer to as far as what that goes. But there is a lot of, you know, particulars as far as insurance stuff. So it's not just a one shoe fits all type of deal. So we kind of we that's basically Haley and I's job was dealing with our patients in the tri-state area is knowing which shoes fit what and how to get patients the care they need for that. So you can go ahead and move on to the next slide. Haley might pop on later to her introduction. She's a farm bee that came from University of Marshall. She's been with us almost 3 years now. Um, she got a lot of training there. I had to break her into my way of doing things since I was the elder statesman here. So we kind of have a fairly good process, and we do take care of the numbers wane, but about 800 MS patients across the tri-state area, care coordinating and such. So, but general basics, what is a prior authorization? So, I mean, for us in our realm, it's looking at prescriptions, test imaging, procedures, not that much. And so when we're looking at the 18, 19, 20 MS specialty meds that we're doing, almost all of them require some sort of prior auth once that prescription's sent to a pharmacy. And of course, for the world that doesn't know this, most pharmacies don't capture these medications, so they do come from specialty pharmacies. And so there's a lot more than just, going to your primary care provider who writes you for a cholesterol medication, blood pressure med. You go to your local Walmart and it's there. So here on the back end, when these meds get prescribed, there's a lot more check boxes that go through as far as making sure the patients have what they need and they can get the med in a semi-timely fashion, plus affordability, which is a whole other issue. But we do a lot of prescriptions, which is the biggest amount that we do, but also tests and imaging. All of our patients, which Dr. Ward and Dr. Seacrest can attest to, when they come to our visits, it's very rarely that they ever leave without having an updated MRI order or some other testing, or when they like to throw a wrench at me and give me the outside labs for some neuropathy panel or some sort that kind of is more along the way of figuring out how to get that approved through their insurances. Luckily for us, procedural wise, the only procedure we really do is, spinal taps for diagnostic criteria, depending on if they need it or not. So really procedures in the world of prior authorizations, of course, like surgery procedures, that stuff, but that's not really our world. So prescriptions and tests / imaging are the biggest thing. And as I said before, almost all of our meds require, some sort of prior authorization. Even if they are a preferred agent, they want specifics from the insurances. So you can kick to the next slide. So what happens here whenever we're starting to see the patient? So you know, and we'll kind of go through the process a little bit more, but once the prescription's sent to the pharmacy, and we're blessed because we have a specialty pharmacy that is embedded within WVU medicine now. So once they capture that prescription that's been sent to them, it automatically gives them whether they have a paid claim or not. And so if they get a paid claim, we see nothing about it, we hear nothing about it, we go about our day and move on. Only if it doesn't get a paid claim, right? That's whenever we get notified. And so when you're talking about clinical criteria, things that they need, the pharmacy reaches out for us if there are questions that don't come through whenever they're submitting for prior authorization. So if nobody's heard of it, there's this beautiful thing called Cover My Meds, which I think everybody in the world has heard about now potentially. So it's a third party HIPAA basically software program that almost all insurances use nowadays for prior authorization requests. Back when I started a decade ago, the old way was you literally called and sat on the phone and talked to an insurance representative to start the process for a PA. And now, beautifully, they electronically pull these forms up for you. You submit all the information you need. And then, usually within 24 to 72 hours, the turnaround time, we get a notice of whether it's an approval or denial. So, luckily, I have very good providers that typically know what we're looking for. So, they put all the information we need in. So, there's not as many questions. However, sometimes there are specifics that the insurances want, and we kind of go through that. But once that's submitted, we kind of wait for them to do their thing. Approval, we go about our business. It either gets filled by our specialty pharmacy or it gets triaged to whichever pharmacy benefit manager the insurance requires gets pushed to. All in the while, our back end also makes sure that patients are signed up for copay assistance and those resources because, of course, we know we're going with very high price medications. If it does not get approved, then that's when we're looking at denials. And in the world of medications, most appeals and denials require some sort of letter or peer-to-peer, and we kind of go through that process after we get that notice. You can go to the next slide, please. So one of the big things that we kind of that I kind of saw was lacking, and I think it's probably in smaller offices across the state when you don't have somebody dedicated to do the certain things that we do, is just trying to make sure you have everything together when you submit. It really kind of cuts down the lag time from the patient being seen to the patient getting started. And what we're aiming to do is, right, we see patient comes in to see us, we have a game plan. Like, let's not let the game plan set for 2 to 3 months, right? We want to get these people, feeling as good as they can, as quick as they can, for as long as they can. That's our initiative. And so what we found is along the way is that there's always these hurdles that sometimes the insurance is put on us, that the pharmacies put on us. So we try to make sure that every piece of the puzzle is all kind of submitted at one time. And the reason why is that there's really no delay. We were seeing whenever prior authorizations were being submitted and then paperwork into the manufacturer's hub, the lag time on it was, 2, 3, 4 weeks. And literally there was nothing that had happened. No authorization. The patient just got enrolled in copay card. And then on the back end, things that, a non-doctor's office doesn't know is pharmacies start harassing us for prior authorizations. So we kind of do all that at once. We do their enrollment, we do their PA, have an approval. If it's not approved, we're already working on the appeal before the manufacturer even knows that patient exists. And the reasoning why is that way, one, it reduces the amount of intake that we're taking as far as calls, but there's a loop. We can close the loop when the patient gets the final answer. But also, there's a lot of things that the patients have to do on their end as well. So making sure that they have all of their treatments as far as like their lab work done, if they require any other testing, if they need updated imaging. And those are things that believe me, they will find that and they will want that information when it comes to a PA. Um, and so making sure that all those aspects are taken care of before we actually even send it to a manufacturer, it kind of makes our life easier. And it definitely does reduce the lag time. And one thing that most people don't know, because I've talked to many insurance representatives across over the last decade, most of them do not have a medical background. They're just reading off of a script. And so they're just asking you whatever their script is for questions. So trying to leave little doubt as for what they're wanting kind of makes life a lot easier in the long run. The less gray area, the better for all the above. You take to the next slide, please. So now with having multiple meds for multiple diagnoses, one thing they almost always do is ask us what the specific diagnosis is, whether it's relapse remitting, secondary progressive, primary progressive, clinically isolated syndrome, or radiographically isolated syndrome. They'll want those since there are different criteria, and also the criteria change per insurance provider. So yeah, like I said, not one shoe fits all. So we have to kind of muddy through that and make sure that we have our documentation is in there. One thing that kind of is very hard to do because we do, I'm going to say, catch a lot of patients across the state that are already seeing other neurologists, is that they were on previous treatments from other providers. And so trying to know what their treatment history is also very important, especially when you're talking about like step therapy and we're going to a more aggressive disease modifying therapy. They want to know that you checked off box A, B, or C, or tried A, B, or C if you're trying to move up that ladder of efficacy in most instances. Um, and then knowing why they discontinued, if there's any relevance as far as was their imaging getting worse or symptomatic, like making sure those things are documented, of course, in the chart notes, which our providers have no issues with. But but honestly, like the things below the office notes, MRI reports to labs, any testing, those are all things when we submit a PA, those all go to the insurer. We try to leave zero doubt that there's no reason for why this patient shouldn't be on this disease modifying therapy because it's as far as making sure that we're trying to accomplish what our game plan is. So we can kick to the next slide. So this is just a little bit of a sample of like some baseline labs that we kind of check for which medications we're starting. And when you look at the top three, the glutathione, the interferons, and teriflunomide, almost all of those now they are typically on preferred drug lists as far as step therapy goes. So even though they're preferred, you'll see that the insurances will still want to make sure that we're checking their CBC and their CMP. They're making sure their liver enzymes are good, making sure their white count is staying consistent, and so on. And then as you kind of move down, you see we have a lot more check boxes, and it kind of moves up in efficacy as far as the disease modifying therapies go. And so the only kind of caveat is the S1Ps, which are your Gilenya, your Mayzents, or fingolimod's the generic, and those medications they do require an OCT through ophthalmology and an EKG beforehand. Luckily, we don't have to do any first dose monitoring with the newer medications, but used to do that in clinic as well. But there is a lot of lab monitoring that we do. So we get with lab monitoring, we typically only get shortened periods of time as far as off. So that means that the insurances are holding us accountable for doing our part to make sure that we're staying within the guidelines of what the manufacturers are doing as well. So we do a lot of frequent lab monitoring. Haley does a great job of making sure everybody has up-to-date labs, or if not, we start hounding them to go to the hospital or the lab to get their labs done. But at the end of the day, it's making sure that we're being as safe and as healthy as we can for the patients. You can kick to the next slide. So a couple other things outside of just the DMTs or disease modifying therapies. So we do treat a lot of people's fatigue because MS fatigue is one of the biggest symptoms that we have come through. So we essentially now almost any time looking at medications that deal with as far as stimulants, we look at like an Epworth Sleepiness Scale, mostly because insurances require it because those medications hit that, and then a fatigue severity scale score. And we do have to update those, to check for efficacy because typically insurances only give us a short window to see how those medications work since they have a short acting time period. So typically we can tell within a month or two if those patients if they're actually getting benefit as far as how it impacts their daily life. Another medication we do write for is dalfampridine or Ampera. It's the walking pill. Making sure their creatinine clearance is good. 25-foot time walks. We do those in clinic to make sure that the med's actually doing what it's supposed to. I disagree with there's supposed to be a 25% benefit. However, 25% is a pretty big benefit for some of our patients, depending on their severity scale, their EDSF, their disability scale. So it's more about how do we improve their daily life, and if you can kind of justify that the medication's helping them complete some tasks, and they're good. Um, and then, of course, not MS patients, they have more than just MS. They have headaches, they have seizures, they have all the above. So we have our own subspecialty headache clinic here. However, they do bleed over to us, so we've gotten to know the CGRPs very well in our space because we write a lot of them as well. So knowing all the triptans and kind of the algorithm that kind of follows whenever trying to get patients um, better managed. Um, so we do write for all the Emgalities, the Nurtecs, the Ubrelvies, all of the above. Sometimes I have to remind my providers that they're not headache docs and that they need more stuff, but that's just part of the game. But yeah, so you can go to the next slide, please. And then she actually added the fatigue severity scale, which nothing too crazy. It's just a simple, eight question um, questionnaire the patients fill out, and then we basically have to reevaluate that every couple months to see how they do if they've had any improvement. So, what happens when they get denied? So, a lot of times Haley or myself, we already know it's denied before we ever even start it, to be quite honest with you, because we know the formularies. Um, so when we're doing that, we're trying to look at like what's looking at previous experiences with patients, like what is it they're looking for exactly. Um, so why do they need to skip the step therapy if they were going to a medication that's not on the preferred list? Some insurances, they won't even have some of these medications. They won't even put them on their formulary. So when you submit a prior auth for it, it's not even an option. So trying to get an override for that. You know, just kind of recent in the last 4 to 5 years, we actually have generic forms like the fingolimod and the teriflunomide. So some insurances require that we go to the generic formulary for that. Which unfortunately some of the generics also don't have as good as copay assistance as what the manufacturers do. So we have to try to like navigate that the best we can because at the end of the day we're trying to get patients, on treatment that they can also afford at the end of the day also. But and then off-label prescribing. We do write for some, infusion therapies that are on/off-label, but that typically requires that we have to do some sort of appeal to get them on said treatment as well. Next slide there, please. So I wish Haley was here so she could tell you about all this fun stuff because Haley is the guru of our appeals. But
I
basically,
think she's on, Eric.
is she?
Yeah,
Chime in. I like it.
she unmuted too, so I'm assuming you have wonderful insights to give us, Haley. Haley, if you can hear us,
Yeah.
we can't hear you. Well,
not sure you, you're not hearing, you're unmuted, but you're not
I'll just
hearing
let
me.
you take it back over, Eric.
That's all right, no problem. So what we've learned is that the manufacturers, honestly, they put most of their appeal processes online as far as blank templates. Um, and so does the National MS Society. And so we've kind of just built like generic, not say generic templates, because we do customize all of our templates to the specific patient. And gratefully, in all of the education and the talking with the patient, Haley's got very good insight into them and why we're doing, X, Y, and Z. So this is kind of on the right as an example letter of what goes to our insurances whenever we submit it through. Um, because and we're also, of course, providing the clinical criteria that goes with it, as well as any like references from the manufacturer or any like articles, whatnot. but but she has this for all of our disease modifying therapies. And I say, unfortunately, we do a decent amount of these, especially when we're looking at patients that we're kind of skipping step therapy because they need a more aggressive form of treatment. Um, so this is pretty common. So once we kind of get these sent through, and we get an answer, whether it's a yay or a nay, if it's a yay, then we presume go let the pharmacy know, run the scripts, let's go. If it's a no, then we're looking at trying to see if there's any free drug offerings from the manufacturer. And typically most insurances or most manufacturers, they require at least one PA denial and at least one level appeal denial for free drug involvement. Um, so this is kind of our starter. Some would require a second level appeal, which is kind of overkill because you're just saying the same thing. But we don't see too many of those anymore. And so then going from there, we start into the free drug um, application process, which can be, income verification for the patient and prescriptions and using a third party pharmacy and yada yada yada. All very interesting stuff, I know, but kind of the end game. So we don't really just stop just because of medication gets denied. We see what other options there are out there for them as far as the manufacturer's concerned.
See, Sarah, you raised your hand. You have a
Fire.
question. Go ahead.
Yes, thank you. Eric, I was wondering in the appeal process, there's the internal appeal through the insurance provider, and I love the template and all the information to make it easy to do that. Is there also an external appeal process on some of these denials that the state regulatory agency or anything that folks can?
If we have to move it up that far, so throwing Dr. Ward under the bus here. So I know that she's been on the Medicaid, at least met with them several times, looking at the step therapies with a preferred drug list and what makes sense. So we have went that far. What we've found in the past, and it's only been a couple instances, it typically doesn't go anywhere. At least most of our insurances we found when their guidelines change, they change at a 6 to 12 month cycle. So we're looking at either January or July as far as what their pharmacy benefits, their actual stuff goes. So we typically don't see like exceptions to the rule per se. Um, I will say back when ocrelizumab came out in 2017, which was a whole cluster, trying to get that taken care of, we had to go through a lot of state appeals to do that. And then voila, like in 4 short months later, it was just fixed because they were like, we're getting tired of doing this. So not a problem anymore. But typically, no, we don't really have too many of those that kind of go through. We also know too, like from our understanding is, okay, so we now have all the info. So what are the options that we have? So like if there's another comparable option or something, how can we move from that? Because we also know when you're looking at state level appeals, they're just slow. And when we're dealing with slowness, we just don't want to make our patients wait around, because unfortunately, like we know, the longer these patients go without treatment, the increase it is for them to have relapses or disease progression. So you're trying to weigh out both of those aspects and trying to do the right thing for the patient without also just dragging your feet, right? So, but unless Haley can talk, this is her beautiful appeal setup. She's great. She does like 99.9% of these. She inherited this task off of me, which I'm a big fan of. Um, but but yeah, so she's kind of got it down to an art as far as that goes. And honestly, like it is so hard to run our clinic without having somebody that kind of knows the ins and outs of this process because it does happen so often. But yeah, and we'll kick to the next slide.
Can you all hear me?
Yeah, we got you now.
Oh, okay. I was just going to say that I have found that those appeal templates offered from the manufacturers and even from the National MS Society are not usually successful because they're usually just referencing their own clinical trial, and they are usually just pretty quickly dismissed. So that's why I've tried to make it personal, and I make sure to avoid the word the patient and always make sure that the patient's actual name is in there repeatedly to try and humanize it some. Some insurances, it seems like, are not even reading them anymore. They're just going by, if you didn't meet the criteria, then we're just going to deny it anyway, which for medications that do have the option for patient assistance is not as detrimental to the patient, but then for the ones that don't have that option, it leaves us in a little bit of a bind. But what I do with that template is I actually have it built into Epic. I don't know if everyone is in Epic, but I have it built into Epic so that I put it in a message to myself actually and attach the patient so that everything auto-populates to save as much time as possible. And then if the provider has written a letter, then I will take their letter and put it in there because a lot of the information is stuff that in my template is stuff that is required by the insurance. So just making sure to address all of those portions and then use their clinical information that they include in their letter. But using that Epic template and then just using the 3 stars so that it reminds you what to go in and fill in that's not auto-populated has helped significantly with saving time.
Perfect. Thank you. And then looking at renewals, so typically depending on the insurance, every 3 to 12 months. So they want to know how the patient's doing. Are they, stable in our world's great. They just don't want to see anything, kind of falling off. But even with stable, they still want to see certain things like updated office notes, lab monitoring, MRI reports. They want something that they can grasp onto to make sure that they can approve it. So that's all information that every time we do a renewal, it's basically doing the same process over and over and over again with the same similar information. So next slide, please. So it's football season here. Sorry, our Mountaineers got demolished by Penn State. So, but like we're all part of a team, whether we like to think so or not. But kind of our doctors or the coach, they're coming up with the game plan. Our nurse practitioners that we have here, they're just trying to make sure that the player, the patient, is ready for the big game. So they're making sure that symptomatically they're taken care of in the interim, kind of being their go-to. Haley, our pharmacist, she just makes sure that the patient's ready to go for the big game. Which the big game is when they start their treatments. When they come here from us and they're a new patient, they basically see almost 80% of our team when they come through for a new visit. They see the doctor, they see Haley, they see myself. We're part of their care team. We like to be involved with it. And Haley's just not a great educator, but she just makes sure that all the ducks are in a row for the patient to be started, to make sure all their lab works good, to follow up with them, any questions, especially we get in the flu season, COVID vaccine time, making sure patients, we're hitting them at the right time if they're on certain disease modifying therapy. So we're increasing their efficacy. And then me on the back end, it's a very vague, I coordinate patient care, but like I'm like the first line of defense when patients call or for scheduling or coordinating their MRIs or those things. Um, it's been like an honor for me the last 10 years to get to know most of our patients, very personally mostly, but to we do a great job of expanding our team in the last 10 years, and like the amount of reach that we have now is like it's very important to the people of our state. And we just hope that like it continues to grow in the next several years as long as they provide us the resources. And of course, the patient's the most important part of that. Making sure that they know that we're all on the same page and that we're all acting on their best behalf to make their life as good as what we can do with, I'm not going to say the unfortunate disease, but what the hand they're given. And also letting them know that just because the hand they were given wasn't what they wanted, they can still do a lot with it, and to keep them, as normal as they can be for as long as they can be, and just take care of our stuff. But that is all I have for that. Next slide. And that is our MS team here in Morgantown. Haley, since she doesn't have the camera on, is the blonde. The redhead there's Erica Blackwell. She's one of our nurse practitioners. Julie, the brunette on the right-hand side, is one of our nurse practitioners. And then Dr. Seacrest, myself, and Dr. Ward. That is all we got for you. Thank you. Any questions? Sorry for talking so much. Like I can literally just wing this in my sleep, and I didn't even. Haley like was making more slides, and I was like, "You don't need to do that."
I do have a question. Do you ever reach out? I'm a case manager. That's why I'm asking this. Do you ever reach out the insurance company and get a case manager for the MS member? Because I know a lot of times we can advocate for them and we can go to the medical director on their behalf to try to get the medication for them, which may not usually be authorized, but we can put in our 2 cents. We can add our opinions, what we have found, what we have talked to the member, what we have learned personally. And a lot of times it sways the medical director our way, your way.
Yeah, so in certain instances we honestly most of and I not to like not to bash like certain insurances, but most of your commercial plans, those members do have a case manager. And they, especially when it comes to our infusion therapies, they're very good at reaching out and making sure that one, most insurances, they want to sway us to use whatever infusion company that they're contracted with, to be quite honest with you. So we do touch base with them as far as that goes. Unfortunately, in the great state of West Virginia, using some of our Medicaid services, that hasn't been super resourceful, getting people started on treatment. Um, but some of our other plans we have, when we have reached out to a case manager, they they can get the ball rolling a little bit better. But what I've also found is, we also got to tying the patient in the loop makes it the easiest aspect. Um, just because they tend to get things more done than whenever they reach out, than what I ever could. At least that's been my experience. And we try to we want the patients to also advocate for themselves, and a lot of them already have embedded case managers that follow up with them on certain aspects of their stuff. It is so much easier for them to be like, hey, this is what's new. Can you call my doctor's office and see where this process is? Because typically, once that happens, if I reach out, it just kind of goes into a voicemail list of whatever, whatever, whatever until they catch up to me. And that's just been my experience over the years. But whenever typically the patient advocates for themselves and they let us know, yeah, it does get happened. It's done a lot quicker, that's for sure. And then sometimes honestly, like I've also found that case managers are just kind of stuck too. That we've had similar instances where case managers are just kind of we hear you, we know what's going on, but unfortunately this is what they're my hands are kind of tied on this one. So but it does prove benefit. Thanks for the question.
Yeah, I mean, I just know, well, and not to bash anyone else either. You know, you have the case managers or they're just doing their job. Then you have the case managers who are mainly very big advocates. I mean, I have 14 people under me, and we're all West Virginia Medicaid. And unfortunately, we can't help with anything PO. But if it's IV and it's given in the office,
Yep.
we can I mean, we're a small insurance company, so we do authorize stuff that the state doesn't.
Right. And I've also found that too, because you said that so a lot of unfortunately we don't give anything in office since we have an infusion center. So
Well,
that's what makes it tough for us too.
well,
Um,
that is the same too. I mean, what we under West Virginia Medicaid, anything given in an infusion center is the insurance company covers. If it's given home health, if it's given PO, we have no say. And I have members who call and complain because RDT has taken forever to authorize it, which I don't understand because Medicaid rules, just so you know, is 7 days.
yes. 7 days for that and 30 days for an appeal they can take up to, which I typically we don't see. It depends. It kind of ebbs and flows. We'll see 30 days occasionally, but not typically. Any,
Thank you, Eric. The presentation's really been fantastic. Tons of helpful information. I was curious when it comes to getting the approval for disease modifying therapies, you know, with research showing the earlier folks start on it, the better outcomes, even if they're not experiencing significant relapses. Is that part of the prior authorization process? Is it difficult to get patients early on those treatments? Would, you know, rural local providers without the network of the specialty care have difficulty demonstrating that to the insurance?
yeah, it's very tough, especially because the insurance has put barriers on those higher efficacy drugs. So we've learned that we're talking about newer diagnosed patients that we're putting them on high efficacy drugs to prevent in the long run. They typically their tiering is their second tier or non-preferred medications. So essentially when we're talking about these patients, like Haley and I know these are already denied right off the bat, no matter what we submit. Because once again, the person on the other end that is reading our criteria, all they are reading is what they have as far as their script goes, and they're just answering it based off that. So those patients kind of get escalated up to. We know there's an appeal, so we kind of start the appeal process fairly quickly. Occasionally, we get that process approved early, which is kind of a fluke, so we don't really bank on those. And then on the back end, we're already looking at what other options from the manufacturer for free drug. Getting whatever paperwork that the patients need, because a lot of the free drug patients they do require income verification, which is like the patient submitting a 1040 or just having their name on a dotted line to go to their patient assistance program. And so we kind of go ahead and start that process at that same time if we kind of know that it's not going to be approved by the insurer. Um, because if we wait for those things, we're talking months down the road from seeing a patient today to actually getting them started on treatment. Um, once once say said patient like gets appeal denied, insurance is not approving it. We get manufacturer approval from the actual for free drug. Most of our outpatient infusion areas in the state they keep backup, so we just ship them a supply to replace their supply, and we can get patients started on treatment fairly quickly. So But but honestly, like 95% of the time, Haley or I know if it's going to be approved or denied before the patient ever checks out of their appointment.
Yeah, I think that we approach every patient as if it's going to be denied just to try and save time. But I will say that within the last 6 months, almost all Express Scripts plans have started to favor like Kesimpta as first line, which is huge because that's been probably one of the biggest barriers is having to go through step therapy to get to that. But other high efficacy therapies, well, the only one that really goes through prescription benefits regularly would be Mavenclad, but it still does require failure of other medications usually. But with like Medicaids, usually they're always going to require step therapy failure. And there are some particular Medicaids that are almost trying to make it impossible for patients to get the medication. So there's one in particular that it seems like every time that you think that you have met the criteria, they update their criteria and just add one minor tweak to it so that you don't meet the criteria and then you have to wait or you have to submit an appeal and they take 30 business days to review that appeal. And it's frustrating for the patients and for everyone involved. So if you're not checking their criteria before you submit the authorization, then you're almost stuck in a loop where you're just waiting and waiting for almost 2 months to get a response from them. And you can't refer them to free drug until you have that appeal denial either. So we're literally just stuck at the mercy of these insurances a lot of the time.
And I will comment, it's not a West Virginia insurance, by the way, just so we're all aware. It's a Maryland insurance. But but yeah, we came across that one that they like to update their criteria just enough every single time. And that's honestly that's what makes it so difficult to get these patients started on treatment is because you need somebody like a Paley or I that are looking at their formulary guidelines like pretty regularly to know what's changed because they will change it. And the status quo of last week will not be the same this week when it comes to that.
Yeah, I like the process of going in that it's going to be a denial. So you can start cutting time and getting access for the patient. That's great.
I had to break Haley from it. She came from Marshall where they had a pharmacy and they had some initiatives that they could help getting patients started. So that's kind of how I just assumed that nobody got approval. And so this kind of went from that process from there. And it seemed to work quicker if I went that way than assume everybody was approved. But any other questions you guys have for us?
Yeah, this is Dean Gunner. I was just wondering on peer to peers. When docs do peer to peers, is the insurance physician, is that a scripted talk to? Do you know?
One of
I
our, you say you could probably one of the doctors could probably answer. Haley's done a few of them, but she could probably tell you for sure.
As far as the health plan, it is not scripted. It is totally peer to peer, doctor to our doctor. And a lot of times our doctor will overturn it if it's even a compassionate reason. I mean, I don't know about big, like the Blue Crosses and stuff and the Cignas. I mean, I know a lot of them go, they don't wait, they see black and white and not gray. So I would say it's different every single time, every company.
And also, to most of our providers' defense, it's not really a peer to peer because most of the people making the decision from the provider based insurances, they're not neurologists. They're pediatricians, they're whatever. So their involvement of the day to day of knowing like the neuroimmunology stuff, that a lot of times they are going based off of that. And Michelle, you are very correct because I have dealt with the health plan and had a lot actually overturned based off that I did not think was going to happen, um, based off of that aspect of like a compassionate overturn. Um, but yeah, so It kind of varies, honestly. Um, we don't, like I said, we kind of go with the mentality it's going to be denied either way. It's just a check on the box to get the patient moving forward. Unfortunately, that's the game we sometimes have to play. And sometimes we get those patients on free drug and we get to do it all over again the next calendar year. And so I think that, you know, it can be very cumbersome for offices to try to keep up with that. But yeah,
Any other questions for the group here?
if not, thank you all for your time. This is, by the way, my first PowerPoint slide in almost 9 years. First time talking since that long, even though I talk all the time more. Um, and it was great to see everybody so interested in something that can be so mundane and monotonous as what prior authorizations are. So I really do appreciate the questions. It actually makes me feel like I didn't, not to say waste my time, but you guys were very engaged. And I really appreciate that.
No, we appreciate Eric, Haley. We appreciate that you're battling some Zoom issues. We appreciate you getting through those and joining us. It's great information. It's useful information. It's information everybody needs. So thank you again. We are going to wrap things up. We'll meet again on October 2nd. So if you guys have any questions or anything like that in between, please let me know. We'll also make, if Eric, Haley, you guys are okay, we'll also make the slides available to everybody if that's okay. Awesome.
Yep. And
All
we're
right.
our email. If you have any information or any other questions, we'll try to help you as best we can.
Awesome. Appreciate it. Everybody have a great rest of September, and we'll see you in a month.
Thank you.
All right.